Welcome back to this last session of this very interesting day. I have the great pleasure to introduce Rod Hedlund. He is the director and master trainer of the Infant Behavioral Assessment and Intervention Program in Kansas City. Rod has an extensive experience of working with infants, staff, and patients. So we are looking forward to listen to you. Thank you.
Great. Okay, I have my sports jacket on. Now I'm taking it off because I would start perspiring profusely if I started talking. All right, the Infant Behavioral Assessment and Intervention Program consists of these core components. It has a theoretical foundation and perspectives. It's process-oriented and reflective in action. It's relationship-based and family-centered, individualized, and validated by evidence-based research. The theoretical foundation is the synactive theory of newborn behavioral organization and development as conceived and developed by Dr. Hedlund Sauls. And she breaks this system down into 4 subsystems. The autonomic subsystem, looking at patterns of respiration. Is it fast, slow? Are there pauses in respirations? Color changes from pink to pale to purplish tinges around the eyes, or gray, for instance, which you would hope that you never see. Neurological indicators such as seizures, tremulousness, or twitches, and visceral or gut signals, such as hiccups, or what we call BM grunts, where they bear down. And then we move into the motor subsystem, reflected in the tone of the infant, the posture the infant moves him or herself into, and the movement patterns of the infant as far as flexion and extension patterns. The state subsystem, looking at the range of states that are available to the infant, how the infant differentiates one state from the other, patterns of transitions from one state to the other. And then embedded in the state subsystem is the attention interaction subsystem, because to attend and interact with the environment and the people within it, one has to be in an alert state. That's the state that you learn from. And then finally, the regulatory subsystem, looking at the self-regulatory maneuvers the infant uses to pay attention, to concentrate, to cope, and to console him or herself, as well as any kind of co-regulatory strategies that the interactor might provide the infant with. Synaction. Syn from the Greek together, plus actio, the Latin action, equals synaction. So it is focusing on the interaction, together in interaction of the subsystems together, at times supporting each other, and at other times impinging on the relative stability of each other, while simultaneously also interacting with the environment at large. The theoretical perspectives include such things as the brain-environment perspective. Early interactions have a decisive impact on the architecture of the brain, the nature and extent of adult capacities, and directly affects the formation of dendritic axonal interconnections or synapses that develop over the course of the child's first 3 years of life. The neurobehavioral perspective, the behaviors expressed by the infant are truly communicative and warrant the keen eye of the observer to support the neurobehavioral organization and competence of the infant as he or she attempts to interact with the important people in his or her world and gradually the community at large. The social interactionist perspective, the task of the professional is to identify how the infant independently attempts to achieve mastery on a task and how the infant's performance can best be facilitated via Vygotsky's approach through the application of neurobehavioral strategies to support the self-regulatory efforts and neurobehavioral competence of the infant. Now, I should say the IBA was created for the infant population once it's discharged out of the hospital. So we're working with a different type of infant now, not the one that was hooked up to the machinery and the emotional roller coaster that parents were experiencing during their time in the NICU. Now they have come home to nest, to be together as a triad, mommy, daddy, baby together, and get to know each other without input from doctors or therapists or nurses, what have you. And finally, the psychological perspective, looking at the formation of an involving, enduring relationship between parents and their infant, appears to be directly affected by the mutual social regulation between the partners in the triad. The IBAIP is process-oriented and reflective in action. The focus of the IBAIP is not what to teach, but how to facilitate learning, a process-oriented approach. The IBAIP supports and sustains the infant's ability to learn about his mother and father, the most important people in his world, about the current cycle of life, what he can do for himself, and what help he needs from others, how to attend to his ever-expanding world, how to support himself, how to calm himself, how to move forward, learning about the world around him. The IBAIP is individualized. The capacity of the infant to learn requires an alert state, a graded presentation of stimuli, and a sensitivity to feedback signals indicating limits of tolerance. It's reflective in action. The capacity of the infant to learn also requires an early interventional professional who has been trained to read the individualized neurobehavioral communication of the infant, the interventionist who can grade or fine-tune the presentation of a stimulus to the neurobehavioral needs of the infant, an interventionist who can support the infant's self-regulatory attempts or provide the co-regulation that the infant is seeking, and finally can reflectively support the infant's parents in reading their baby's body language, interpreting it, and translating it into neurobehavioral support over the course of social and or caregiving interactions. The conceptualization and development of the IBAIP. The IBAIP was designed to improve developmental outcomes in infants born prematurely or with disabilities. And it was also designed to support and enhance infants' self-regulatory competence and neurobehavioral organization, support early intervention professionals to read and interpret the infant's neurobehavioral story and offer appropriate neurobehavioral and developmental facilitation, and support parents as they continue to explore ways to adjust themselves to the neurobehavioral organization and self-regulatory competence of their baby. The IBAIP is validated by evidence-based research. This was the first pilot study that was produced by Koldewijn and Wolf at the Academic Medical Center at the University of Amsterdam. And their results, it was a small N of 40, and they found significant gains were found for both mental MDI and psychomotor developmental indices on the BSID-2, as well as demonstrating clinically significant differences in neurobehavioral competence in favor of the intervention group. They then received funding to conduct a much larger study with an N of 176, and then did follow-up on these children that received the intervention. I trained the physical therapists that provided the intervention, trained and certified the physical therapists that provided the intervention in the experimental group. So at 6 months corrected age, the IBAIP improved the infant's motor development, mental development, behavioral development, self-regulatory competence, and mother-infant interaction. At 24 months corrected age, the IBAIP improved the infant's motor development. At 24 months corrected age, the most vulnerable infants profited most from intervention, affecting interactive, behavioral, mental, and motor aspects of the development. Infants such as infants with BPD or gestational ages less than 28 weeks, abnormal cranial sound, ultrasounds, a combination of social and biological risk factors, etc. At 24 months chronological age, children that received intervention needed significantly less paramedical support. And at 44 months corrected age, the IBAIP improved independency and mobility and sensory processing. At 5.5 years, the IBAIP leads to improvement in intelligence, ball skills, and visual motor integration. They also, Kuldevine and her colleagues also looked at the reliability, sensitivity, and responsiveness of the infant behavioral assessment used to determine the organizational competence of the infant. And they used the methods of videotape assessment of very preterm infants. For rate of reliability was based on 40 video scored by 2 independent observers, and sensitivity was evaluated by comparing the IBA results of 169 infants at 35 to 38 weeks post-menstrual age. And the responsiveness, the effect size, or ES, was calculated between 0 and 6 months corrected age in all intervention and control infants. And the results they found for the IBA included inter-rater agreement was 93% in the total assessment. The Kappa agreement was moderate to good in the behavioral categories, and significant differences were found between groups with or without risk factors. Larger differences between ESs in the randomized control groups with oxygen dependency at 28 days than in the total randomized groups reflect the responsiveness of the IBA. So their conclusion was that the IBA is a reliable and valid tool to evaluate and support neurobehavioral organization in very preterm infants. Satisfactory to good clinometric characteristics of the IBA were found in very preterm infants, but of course additional validation in the IBA in different infant populations at different ages is warranted. Future research of the IBA, Professor Jacques Cizoun in France, in Brest, France, is going to be conducting a multi-center cluster randomized study in 8 NICU follow-up clinics with 340 infants, and we'll begin training that group in the experimental group sometime in the first of the coming year. I've also just returned from Tehran, Iran, and they have requested training in the IBA-IP as well, and have a big support group from UNICEF as well as from the Ministry of Health and the Department of Medical Education. So the IBA-IP curriculum consists of the infant behavioral assessment, the IBA training manual and operational definitions, the neurobehavioral curriculum for early intervention, the self-regulatory competence scale, and holding parents holding their baby. The IBA, the infant behavioral assessment. We drew upon a number of other pre-existing assessments, behavioral assessments, such as the nursing child assessment teaching scales that Bernard developed at the University of Washington in Seattle, Washington, the assessment of preterm infant behavior, and the naturalistic observation of newborn behavior developed by Alls and her colleagues, as well as the Brazelton neonatal behavioral assessment scale that basically the state system from Brazelton's group. Again, the 4 subsystems are represented as far as autonomic, motor, state, and attention interaction. And the organization of the behaviors. There's 4 subsystems, We have 26 behaviors in the autonomic visceral subsystem, 44 behaviors in the motor subsystem, 9 state behaviors, and 34 attention interaction behaviors. This is the IBA itself. It's hard to read. I know I'm showing you what it looks like. It's divided into the autonomic system here, the motor system here, the state, and finally the attention interaction. And then it has subgroups of behaviors underneath. There's a total of 113 behaviors. On the back of the assessment is called the observational record, and that's for one to be able to just list information for 4 different observations. So the date, for instance, the time the observation was conducted, the name of the infant, the age of the infant, the chronological age of the infant, who was rating the assessment, who was interacting with the infant, what was the environment at large like, and were there any kind of antecedent events that occurred prior to the observation. These observations started about 1 to 2 minutes, but as the person that is being trained in the IBAIP becomes more familiar through practice, can actually do a whole hour of intervention and keep the behaviors in their head to score after the intervention has been ceased. And so we're going to go through looking at some behaviors as they emanate out of the infant's 4 subsystems. What do you see here? Take a look at the mouth area. If you look really carefully, there's a little bit of spit up coming out. So we have a bit of an unstable autonomic system. What do you see here? Pardon me? Yeah, there's some modeling going on the skin. The capillaries are showing themselves on the surface of the skin. But also, this infant is trying to brace into the supporting surface with one foot, and the other foot is also foot brace to foot sole to foot sole. Here we have an infant feeding. The state is about diffuse alert to drowsiness. The infant is holding on to his finger, a self-regulatory maneuver, and has also brought hands into midline. Again, another nice example of foot bracing, and you have some toe clenching as well as toe splaying in the other foot. Sitting on air. You find this always a lot in medically fragile infants. This child had Down syndrome, and also severe heart defects. And when they get stressed, those little legs fly up into the air. Okay, shoulder retraction and fisting of the hands. This kind of a wariness on that baby's face, not sure what the therapist is about to do to her, and she's making attempts to brace into the therapist. Nice en face, directed gaze with the mommy that's holding her, and she is also groping upon mommy's fingers as a self-regulatory mechanism. Hands to midline, hands to mouth, and hands perhaps groping on to their own clothing as a self-regulatory mechanism. Big smile. This is a nice example of the whole facial component of facial brightening, with the eyebrows raised up, the eyes wide open, the smile, the cheeks raised, hands on stomach a little bit, maybe trying to grope on mommy's hands over to the side there. This is what we call Ugg face. It's like the configuration of the face you say when you smell like something bad, like sour milk, for instance. And there's some finger extension going on and some attempts to grope on and possibly hold on to their own clothing. And wariness, facial component. Not sure what the next activity is going to be presented, and she seems to be somewhat wary about what the interventionist is about to do. You also have hands brought into midline and on tummy, perhaps some bracing with her feet down below. Now, we a priori categorize the behaviors as far as approach, self-regulatory, or stress behaviors in each of the 4 subsystems. Now, the behaviors are categorized as approach, self-regulatory, concentrate, cope, or console, and stress. Approach indicates that the sensory information that is being received by the infant matches the readiness to process and learn from it. So here we have a perfect example of an approach behavior coming out of the autonomic visceral approach behavior. The autonomic system is stable, motor approach, head orients to the adult, state approach, interactive alert, attention interaction. You have approach behaviors such as smile, facial brightening, facing gaze, and eyebrow raising. Again, another example of approach, stable autonomic visceral, motor approach, head orients to the adult and reaches to the adult's face. State approach, interactive alert, is very invested, looking up at daddy. Daddy's blowing through the child's hands. An attention interaction approach, you have facing gaze. Now, looking at self-regulatory behaviors, these are strategies that the infant uses to maintain a balanced, relative stable state across and among all 4 subsystems, or to return to such a state of balance. And these are divided, self-regulation behaviors are divided into these 3 categories: concentrate, cope, and console. Self-regulation, as far as concentrate and process and learn from the stimulation that is offered. So you may see a baby, as a toy is presented to them in midline, bring their hand up to mouth to suck on. But that's the only thing that they need. They're just using this as a means of helping them look at the presented object, for instance. Self-regulation as coping mechanism, or is to hold on or to contend with a presented or more challenging developmental task. So now we go from presenting an object for the baby to look at in a stationary position, but now we start moving that toy. We're asking the child to do a little bit more, to track the object as it's moved across this horizontal visual field. And that may cause that particular infant to become a little somewhat distressed and call on more self-regulatory behaviors, such as bracing with their feet, bringing their hands to mouth, maybe clutching on to their own clothing. And as an interventionist, you would want to read that as, okay, he seems fine with this, stabilized. He can track across horizontal visual field, but if I ask him to do much more, if I start talking to him, that might push him over in distress. So you don't want to add anything more on top of what you're already asking him or her to do, because they're already communicating that by calling on all these other self-regulatory behaviors to cope with, that it's a cautionary yellow light. And finally, self-regulation is used for the infant to console. An infant who becomes unhappy or stressed, the information that is being presented to the child is not appropriate in terms of the timing or the organization of the baby, or that it's too challenging. And we look at specifically what the baby does to try to self-console and bring themselves down into a more organized state. So here we have self-regulatory used for concentration, holding on, hands to midline, state approach. The child is in alert state, interactive alert state. They are actually looking at the toy and attention interaction approach, facing gaze, looking at the toy, and ooh face, trying to reach out with the toy with their lips. And daddy is nicely supporting the baby in his hands, keeping the lower extremities nicely flexed and her arms in to midline, which she actually interdigitates her fingers and holds on to. Looking at the autonomic visceral, we have self-regulatory behaviors now being shown as a coping behavior, such as yawning, motor, coping, hands to head or hands to eye, self-regulatory coping. Some infants remove themselves from an interaction by moving their state system down to a drowsy or even checking out by moving into a sleep state. And attention interaction, stress, you see beginnings of stress with the eye clenching. And then motor self-regulatory consoling. This baby was crying just before daddy quite nicely, naturally, intuitively placed his finger in her mouth, and she used that to suck on and calm herself down. Also, the baby's brought her hands in to grope upon daddy's hand or try to hold on as a means of coping. Consoling, I'm sorry. And then finally, we have stress behaviors that indicate the sensory input that the infant is receiving is too intense, too frequent, too long, and too complex, and results in subsystem disorganization. And a perfect example of that is this whole cry face scenario where you have the clenched eyelids, the lowering of the eyebrows, the jaw extension, and the active cry, all showing out of the autonomic motor state and attention interaction. Now, you must keep in mind, however, we do not, each behavior that we view is part of a continuum. Approach and self-regulatory behaviors can shift over and become stress behaviors. And some stress behaviors are successful in reducing stress and therewith become self-regulatory strategies. So you can't really categorize them. We do just as a point to assist people to get to know the behaviors, but some babies will start searching for something to brace up and support themselves with their feet. And if they find something and utilize that, they're successful. That's great. That's a self-regulatory behavior that they may be utilizing to keep themselves together as they're being presented with a specific assessment item or task to be engaged in. However, if you see foot bracing going on, they're searching for something, they kind of get a ledge or the foot roll to brace up against, but they keep on slipping off, and it becomes more frantic attempts to foot brace, then that is a stress behavior. So the IBA appropriate infant populations, the medically fragile population, high-risk premature, developmentally delayed, neurologically impaired, drug, alcohol exposure. Appropriate population, again, birth through 8 to 12 months corrected age. The infant has been transitioned home from the hospital, and older infants with any kind of neurological impairments or developmental delays with associated CNS functioning in the birth to 8 to 12 months age range. So we have utilized this with infants 2 to 3 years of age who are functioning still at about like 8 to 12 months of age. Training qualifications. The IBA is offered to all these early intervention professionals, infant developmental specialists, pediatricians, physical occupational therapists, communication disorder specialists, visiting home nurses, social workers, anybody that comes to the home to see and be with the infant and family to provide specific services for them. Experience with newborns or young infants is required, and knowledge of neonatal medicine, infant development, and standardized testing is helpful. IBAIP training is most well suited for clinicians who are already skilled in their own practice and whose current practice includes interventions with high-risk medically fragile babies. Observational materials needed to conduct assessment, the trained eye of the observer, IBA and operational definitions, a clipboard, a stopwatch, age-appropriate toys, and co-regulatory supports as needed. The observation can be an actual real-time observation with the baby, or it can be scored off a video or DVD sample. Observation period tends to be 1 to 5 minutes, and observed episodes, caregiving interaction, social interaction, intervention session, or an assessment session. And for actual observation, the interaction is usually conducted by someone other than the observer. But this changes as you get more and more familiar with the use of the IBA. And you can actually do an entire intervention session and record the behaviors that you're observing in your head. Because the babies do not display all 113 behaviors. They have a repertoire, an individualized repertoire of behaviors that they use to communicate their needs and wants. Again, whole time interval sampling, Rader observes the entire episode. So you sit there and you watch, whether it's 2 to 5 to the whole intervention session. And then after that, you immediately score the IBA. You don't want to score while the interaction's going on because you're going to miss too many behaviors as they're displayed by the infant. Successive sessions are also recommended to control for variability of behavioral responses. Then we develop the IBA report, and we reflect upon the infant's responses to sensory input, the integrity of the 4 subsystems, the neurobehavioral and self-regulatory competence of the infant, and need for co-regulatory support and infant's goals. It's very similar to the NIDCAP write-ups for those of you are NIDCAP trainees or already NIDCAP certified. And the things that are addressed in the behavioral story includes the medical history, the ambient environment before the interaction, during the interaction, after the interaction, a neurobehavioral summary and recommendations and a plan for how you're going to present yourself and what things you're going to work on in the future for this particular child. And these just provide, I'm not going to go read all of this. This is like, from this behavioral observation, Jonathan appears to be quiet, comfortable in his new home, and well supported by the natural intuitive care of his parents. He makes many efforts to support himself, and we list out some of those supports and self-regulatory behaviors that he actually utilizes, and then provide that with a behavioral summary. And then we look at identified goals that Jonathan is working towards, such as more robust and steady breathing, conserving and maintaining energy for the duration of feeding, graded social and toy play, and increasing effective use of self-consoling behaviors, such as bringing his hands to his mouth, tummy, grasping onto something that he's offered, like a finger from an adult, etc. And then, of course, we bring in the parents and assist them in reading through the behavioral repertoire of their baby. Sometimes we videotape and then replay the videotape with the parents and ask what the parents are seeing their baby trying to do. And then we follow that up with recommendations, such as continue to provide Jonathan with a deep, softly made bed, continue to support Jonathan's desire to hold on to an object, continue to be aware of Jonathan's cues, etc. Infant neurobehavioral intervention is the neurobehavioral curriculum for early intervention. And that's divided into 3 different specific categories: the environment, handling and positioning, and cue match strategies. In the environment, we address ambient visual environment, ambient auditory environment, temperature within the environment, and the social viditory auditory input. Handling and positioning, we look at the supine, baby on the back, baby in prone, sideline, cradled in arms, held at the adult's shoulder, or held face-to-face in the adult's lap. And then finally, cue match strategies. These are the strategies the infant may be showing us, such as bringing hands to mouth, sucking and mouthing, bracing and foot clasp, holding on, hand to midline, and hand on stomach, and also any kind of self-clasping attempts the infant does. Application of the neurobehavioral strategies. Based on Vygotsky's work, we look at the infant's self-regulatory and neurobehavioral competence, which suggests the degree and quantity of the neurobehavioral co-regulatory strategies that may be offered to the infant. This is an example of the zone of proximal development as developed by Luria Vygotsky. Here is the actual developmental level of the infant, and with adult guidance and mediation, what you can do as far as assisting the potential developmental level of the baby. So we took this and developed into what we call the zone of neurobehavioral organization and self-regulatory competence. So down here is the infant's current neurobehavioral organization and self-regulatory competence. Is it optimal? Where's that? Yeah. Optimal, high, moderate, low, or minimal. And then we look at, depending on where they are as far as their neurobehavioral competence, how much the degree, such as minimal, low, moderate, high, or do we need to terminate the interaction because the baby has become so stressed, and the quantity, such as environment, handling and positioning, and cue match strategies. So we look at how much and what types of neurobehavioral intervention that we provide to this particular baby to get the optimal potential neurobehavioral organization and self-regulatory competence. So if the child has optimal self-regulatory competence, obviously they would need minimal support from the adult. If they have a high degree of self-regulatory competence, they have low need for facilitation. Moderate self-regulatory competence, you have a moderate degree of facilitation. Low self-regulatory competence, a high degree of facilitation. And if the infant has a minimal bit of self-regulatory competence, and they are starting to disorganize, you stop your interaction with that baby and look at what you need to best support them, because whatever you're doing to them, you've disorganized them. And they're not going to learn from that experience. This is a self-regulatory competence, and we just labeled it again, optimal, high, moderate, low, and minimal. And then on the other side, we have this is for supine upper and lower trunk and extremities. We have specific strategies that one would offer that baby depending on where they were as far as their self-regulatory competence. And this is a self-regulatory competence scale that is scored on a 1 to 5 point, looking at all the subsystems, the autonomic, the motor, the state, the attention interaction, and the self-regulatory competence of the child. And we score this after the IBA has been conducted. Okay, neurobehavioral strategies. Motor supine co-regulation of the upper, lower trunk and extremities. So towel rolls have been used on the sides of the child to keep the shoulders and bring in the hands close to midline. The child is actually holding on to the interventionist's fingers there, and the interventionist is also supporting the infant's tucked in lower extremities. Loose swaddling is offered to support the infant's self-regulatory attempts to bring hands to mouth. We do not tightly swaddle babies. If you do that, you take away a very important way that they use to self-regulate, which is their hands to mouth to suck on or their hands to their head. And then that also supports the extremities and foot bracing into the adult's inner arm. Or a towel is shaped in the form of a nest to provide co-regulatory facilitation. This supports the infant's self-regulatory attempts to bring hands to midline, holding on, hands to face, and foot bracing. All right, let's take a look at this little girl. She's way out there. We've got airplane going on. She's sitting on air with her feet. she's looking off to some other person off to the side of her. The intervention is in front of her on the other side. Is any learning going on in this particular situation? No, she's highly disorganized motorically. So what the interventionist then does is brings in her feet, holds them together, and flexes her lower extremities. And now, but we still got the arms out to the side, of course. So the interventionist goes in and holds the feet together, flexes the lower extremities, and brings the arms into midline, and also holding on to her own clothing or the interventionist's hands. In this situation now, the interventionist has removed the support that she provided to the feet because the baby has taken over this all by herself. She now is foot bracing with one foot into the supporting surface and also a foot clasping with one foot sole against the other. But support is still being offered with the hands because you don't want to overprotect the baby. You don't want to over-facilitate the baby. You want the baby to learn how to self-regulate themselves. So we're still holding on to the hands. The feet are still okay. The legs are flexed up, and the feet are making attempts, still pushing against each other. Hands are still being contained. The toy is introduced. And lo and behold, the feet are maintaining themselves in nice self-regulatory posture. One hand is now reaching up and has actually made contact with the toy, and the other one is just being gently facilitated in midline. The infant is presented with the toy and is now able to effectively use all the self-regulatory mechanisms that were first promoted by the interventionist. She can now bring her hands into midline and maintain them there, brace and use the supporting surface of the floor to push up against, and follow the ring as it's presented to her. So we first assess the neurobehavioral organization and self-regulatory competence of the infant, which leads us to support the infant's self-regulatory attempts and apply neurobehavioral co-regulatory strategies as determined by the initial assessment, which enhances the infant's self-regulatory competence and thus increases the infant with new opportunities to be engaged by and engage in social interaction, which then facilitates the infant's ability to learn from his environment at large and through the daily interactions with his family and community. The goals of neurobehavioral intervention are to support the infant's subsystem functioning, support and facilitate the infant's self-regulatory competence, facilitate the infant's optimal attention and interaction capabilities, because again, that's the only state when they're attentive and interactive that the infant can learn from. And then you want to minimize infant stress and subsystem disorganization to facilitate the developing infant-parent relationship, promote brain organization and development, decrease needless expenditures of energy, increase opportunities for learning, increase the infant's exploratory interests and desires to participate, and to decrease the need for early intervention services over time. And the goals, of course, continue to support and validate and facilitate parental perception of the infant's communicative and developmental confidence and parental facilitation of their baby, support infant and family along the pathway of success and independence, and improve clinical skills and practice of early interventionists and healthcare professionals. And then move from a developmental assessment curriculum-based intervention. Instead of, in the United States, we have interventionists going into babies' homes and doing to the baby, because that's what they've been taught to do. This was developed, the IBAIP was developed to help interventionists see what the baby is doing and read the behavioral cues, support the baby as they introduce specific activities or assessment items, or are helping mommy and daddy care for the baby. But moving away from doing and first looking and seeing what the baby can do for him or herself. And for some reason, we lost a picture in that. The emotional world of the infant. The story of a human baby begins. Being does not start at 5 years or 2 or at 6 months, but starts at birth and before birth, if you like. Each baby is from the start a person and needs to be known by someone. No one can get to know a baby as well as the baby's own mother can. These are the written words of course, D.W. Winnicott, who was the pediatrician and psychoanalyst, who did an incredible amount of work and help in supporting mothers and fathers and being with and for their babies. The mother's aliveness and physical management provide an essential psychological and emotional milieu essential for the baby's early emotional development. And I love this. It all adds up. The act of feeding, dressing, changing a diaper, being alone together to enjoy each other's company over and over and over again, it all adds up. The infant finds the security, relatedness, and unconditional love through the parents and families' nurturance and cherishing of their baby, setting the foundation for the infant's emotional development and the ever-evolving parent-infant relationship. Holding the infant before and after birth and as the child grows and develops into adulthood. Supporting the evolving parent-infant relationship. This is the parent component, parents holding their baby. So the questions asked are, how can we support and nurture the parents' cherishing of their baby? How can we support and nurture their parents' confidence in caring for and taking pride in supporting their baby's development? How can we safeguard the parent's role? And how can we support the parent's desire to find their own way with their child? Supporting the evolving parent-infant relationship involves engaging in an ongoing relationship with the infant and family through the process of reflection, the process of feeling, seeing, or noticing what you are doing, then learning from what you feel, see, or notice, and finally, intelligently, even intuitively adjusting your practice. So while you are engaged with an infant or engaged with a parent or engaged with another staff member, it's like an out-of-body experience. You're also watching yourself and the way you're interacting with that parent or that baby or a staff person so that you can correct your behavior if you're getting feedback signals from any one of those three partners in the dyad that I just listed out about how you need to make different arrangements with your interaction. Reflection as an individual and shared experience. Reflection before the interaction, preparing for the moment. So you've got to get rid of all of the daily activity business that you have in your head while you're interacting with that baby or that parent or that staff member. That all goes away. You're in the moment. You're working, interacting with that parent in the moment during that specific time. Then reflection during the interaction in the moment. And then finally, reflection after the interaction, after the moment, where you actually reflect not only with yourself, maybe with a peer, maybe with a mentor, about how that interaction went during the course of your engagement with that infant. I'm going to flip through these because I want to get to just the actual materials. So the reflections upon Winnicott, these are materials created for the baby. They're based, thank you, that are based on Winnicott's approach to caring for infants and their parents. And they're just like discussions of some of the things that he addresses in his book, Babies and Their Mothers, feelings of oneness, or holding, or feelings of getting to know each other as a mommy and daddy and baby together. Then we have a section called Talking with Parents, such as there's no such thing as a baby, enjoying being a mother and father, holding your baby, being a mother and father, a very natural thing, trusting who you are, let the world go away just to be with your baby. You can't spoil a baby. A lot of times parents come home and they don't feel like they know what to do with the infant now that they don't have people telling them what to do with their baby like they had experienced in an NICU. So just their simple pleasure that they can get from being with their baby, letting the world go away, lying back and floating, and just holding your baby, letting the baby feel and hear your breathing, your heartbeat, and the soft voice as you coo or sing to your infant. This is what we call, this is one of the parent discussion items. Let the world go away, the world turns and night becomes day and day becomes night. We all wake up in the morning to another day of things to do and places to go. Sometimes this doing and going gets in the way. It gets in the way of actually enjoying the living of our day. And it goes on to list out, yes, the laundry needs to be done, or the lawn needs to be mowed, or Grandma and Grandpa are coming over for a visit, et cetera, et cetera. But we really want to encourage the parents to let the world go away, to be alone with your baby, to love and be with your baby and for your baby. So they're not always feeling like they have to be doing something with their baby, but enjoying their baby. Neurobehavioral considerations are also part of the family materials, and we're looking at the environment, handling and positioning, and cue match strategies, such as helping your baby see the world. So many things to look at. Sometimes these homes the parents' homes may have many overstimulating pictures with the television going on, the radio going on. We try to help the parents see how that might affect their infant's ability to tend to mommy and daddy speaking to them, and probably avoiding the television on when you're trying to interact with the child. And this just goes on to sounds in the environment, things that we hear, something to hold on to as a self-regulatory strategy. Mommy's promoting hands to midline, hands to hold on to, hands to hold on or grasp onto their own clothing, holding on to the bottle as you're feeding the baby. And then organization and IBA training. I'm not going to go into that now. That's in the handout that I left with you, that you have in your brochure, that is specifically addressed. It takes approximately a year to 16 months to receive the entire training. And then the estimated training expenses include all the materials plus shipping and handling, which totals for 8 trainees, a total of $500 per trainee for all the materials and $1,000 for shipping. The trainer's expenses are $20,500 because there's a workshop, 5-day workshop, a written critique of an IBA write-up and and the self-regulatory competence scale, a 3-day IBAP follow-up workshop, and a 3-day certification. That should actually be 4-day certification workshop and trainer's fees. And then finally, the IBA trainer's travel expenses, 3 round-trip airfares, 16 hotel nights, 16-day meal allotments, etc. So it all totals up to approximately $31,000 or $3,880 per trainee for approximately 12 months to 16 months of training. Okay, that's it. Thank you very much.